It's my pleasure to introduce Dr. Andrew Iaboni. Dr. Andrew Iaboni is a geriatric psychiatrist and an assistant professor in the Department of Psychiatry at UC. Many of you know her as a scientist at Kite, and she's also the medical lead at the Specialized Dementia Unit, and she consults at long-term care. I'm not going to talk about the focus of her research because you'll hear about it. We collaborated a lot together, and it's always a pleasure to work with her, so you're in for a treat. Please join me in welcoming her.
I hurt my knee on the weekend. I'm a bit wobbly. All right, welcome. Thank you everyone for being here. I'm really excited to give my first Toronto Rehab research rounds. I'm an affiliate scientist here, but hope one day be a full scientist. I wondered how many people here have been to a long-term care facility or a nursing home? How many people have walked? And how many people here have done research in that setting? Okay, great. So we have people here who know a fair bit about this. But I'm going to talk a little bit about where I see things going in terms of research in technology in long-term care. And I want to preface this by saying that a lot of the public discourse around long-term care homes and the media coverage of these facilities is sort of predominantly negative. But I work in long-term care. I work with a lot of people who work in long-term care, and I believe strongly. I'm passionate about this work and about the care that's provided in these environments. And so I'm hoping that I'm not taking the lens here that these places are bad and we need to make them better. I think that they're good and we can probably support them to providing even better quality care. So that's the lens. You can follow me on Twitter. I'm at Dementia Rehab. I'm very close to 1,000 followers, so that's why I'm promoting that. Okay, so if I could go. Sorry, didn't work. My first space didn't work. Try again. Yes, okay. I don't actually, just so you know, I don't take money from any drug companies. I do a bit of scientific advisor work, but none of these should impact on my talk today in terms of bias. So my talk is sort of divided into 3 sections. I'm going to start off by providing an introduction to what long-term care is, what the setting is, who lives in long-term care, who works there, to help us have the context for the kinds of technology that might have a role in this setting. And then I'm going to go into the challenges in the delivery of high-quality care, and again from the lens of what are the opportunities there in terms of technology, and what are some of the barriers. And then on the last part, I'm going to go into some of the projects that we've done in the setting of long-term care around technology. And so I'm not going into each project in a lot of depth, but covering sort of 3 projects and some of the work and the results that we've had. Okay, that's good. So I'm going to start historically, actually. I'm going to go back to this painting, which was done in 1878, and this is the sort of precursor of the modern long-term care home, and this is a workhouse. In the late 19th century, your odds of getting to over the age of 70 years old was about 30%. Most people did not live that long, and if you did live that long, you were probably impoverished. You were no longer able to work, to support yourself, there was no social support network, and so invariably you ended up in a workhouse. Over time, this has changed. Now your chances of living to over the age of 70 are over 90%. And through this change happened particularly over the post-war period, and that was when a lot of social care was brought in and the sort of modern nursing home was born. This has particularly evolved over the past sort of 20 to 30 years, where we've increasingly become aware about the issues of quality of care in these environments, the need to protect the sort of vulnerable residents, and then legislation came in, and this is where we are now today. We have a highly regulated long-term care sector, which is really part of our health and social security services. So long-term care is a place where adults live and receive help with most of their daily activities, and where they get access to 24-hour nursing and personal care. And in Ontario, this is regulated and inspected and funded by the Ministry of Health and Long-Term Care, and there is actually legislation in place that defines what constitutes a long-term care home and the sort of quality of care that they have to provide there. There are over 600 long-term care facilities in Ontario, the majority of which are for-profit, many of which are very small, so we're not talking about massive institutions for the most part. Basically 77,000 Ontarians live in long-term care, and the average length of stay is a little less than 3 years, although the median length of stay is much lower than that, about 1.5 years, and that reflects that there are a good chunk of people who move into long-term care at the very end of life, who are just there to receive a short period of care before they pass away. But some people live there a long time. Some people have been living in these facilities for decades. At the moment in Canada, this is from Statistics Canada, 5% of those over 65 live in a nursing home, about a third of those over 85, and 2/3 of those centenarians in Canada live in long-term care. And the profile of our long-term care residents is that they're predominantly female, which is typical for that age group. Most people living in long-term care have cognitive impairments. 65% will have dementia, and then the other 25% either have cognitive impairment that has not yet been diagnosed as dementia, or they have other sources of cognitive impairment, such as a brain injury or a developmental disability. And so right now at the moment in long-term care, 86% of residents have what's called complete support with their activities of daily living. That means they need help dressing, bathing, toileting, and feeding themselves. So that's really the bulk of residents in long-term care. And you can see here the age distribution. So over half are over 85, and a very small proportion are under the age of 64. So one of the key points of this talk is that the long-term care population is really changing. People who live in long-term care now are very different than people who lived in long-term care even 20 years ago. In part, that's because we're living so much longer. People who used to die in their 70s of a heart attack or a stroke don't do that anymore. Mortality rates from these sorts of cardiovascular, cerebrovascular causes have really plummeted in recent decades. And so instead we have people living into their 80s and 90s with the sort of vascular burden on their brain, which produces a cognitive impairment such as dementia, but they're alive and receiving care in these settings. So the people in long-term care are now older than they used to be, they're more complex and more frail, and much higher proportions of people in long-term care have cognitive impairment. So it used to be that it was a very small proportion had dementia. People didn't develop dementia at the same rate as they do now. But living longer, aging brains, more people with dementia. And so this population has much higher care needs than people who lived there before. And a 1/3 of residents are what we call entirely dependent on staff. So that's even that they're not mobile, they're completely dependent for all their activities of daily living. And so why this is important is that while the population who live in long-term care are changing, some of the other things about long-term care haven't been changing. So that's things like the infrastructure, the funding, the staffing has not changed at all. And so this puts a lot of pressure upon these institutions to care for people who are living there. So I'm going to go through each of these challenges quickly in the context of the kinds of opportunities that they provide for us in terms of providing technology and AI. So these are things like funding, human resources, the complexity of the resident population, and the demand for these beds. So long-term care took in 2018 $4.28 billion of our Ontario budget, which is 7% of the health budget. It costs $150 a day to care for somebody in long-term care, and the vast majority of that is for nursing care. What this is important to know is that there's very little funding that is put towards capital in long-term care. So if, say, you had an amazing piece of equipment that you thought was going to make a big difference to the care, whether or not nursing homes could buy that equipment is a real question, because there's no funding really provided for that kind of innovation and technology in long-term care. The other thing to note is that if you had an innovation that, for example, could affect the staffing needs of a long-term care, that could have a big impact in terms of the costs that are faced in this environment. So that's where funding comes into this. Human resources is an important issue. So there's like 50,000 people who work in long-term care. Most of this are people who are not registered professionals, so what we call personal support workers or healthcare aides. This is a population which are underpaid and also low skilled. They may not have good language skills, they may not have good computer or technology skills, and so this is the predominantly the population delivering care. And so if you are designing technology for this environment, they has to be for this population of care staff to be able to use it. So that is an important implication. In Ontario, we don't have any minimum staffing ratios, so there's no requirement that you have X number of staff for X number of patients. So it ranges from facility to facility. You could have one staff member for 8 residents, or one staff member for 15 residents. But on average, what we know across Ontario is that an individual who lives in a long-term care home gets about 2 to 3 hours of direct care. So out of 24 hours, 2 to 3 hours will be spent with somebody helping them get dressed or bathed or feeding them or providing medications or doing wound care or providing any other number of medical services. So you can imagine that's actually a very small amount of your day. 22 hours of the day are spent without receiving any help. And so if you can think of technology that can in some way enhance the amount of care that's being provided during outside of those times when the staff are available, then that's an opportunity as well. If you can find technology that can help support the skills of these staff, that's another important opportunity. So this is where we come back to the issue of complexity. So there's a lot of pressure on long-term care homes not to send patients to acute care, not to send them to hospital, and to manage people with more acute care needs in the long-term care setting, in part to take the pressure off of the hospital care systems. And so increasingly, nursing homes are caring for people with more complex medical needs or even acute medical needs. And so 40% at any given time of people in a long-term care will have some kind of monitoring need for an acute medical condition. The other thing that's happened in long-term care is, particularly with the deinstitutionalization of chronically mentally ill populations, like you guys know, this is a whole other story, but a lot of long-term psychiatric institutions closed down over the previous 30 years, that you have a population with a lot of psychiatric needs living in long-term care. So 40% will have a psychiatric disorder such as bipolar disorder or schizophrenia, sort of chronic and persistent mental health conditions. And so are the staff prepared to care for those psychiatric needs of these patients? Do they have the resources? So those are a couple of opportunities. How do we support the skill of staff around these more complex patients? Finally, there's a real concern about safety in long-term care, where there's in conjunction with people with cognitive impairments or mental health concerns, people can exhibit behavioral and psychological symptoms, sometimes called responsive behaviors in these settings, and can exhibit aggression either towards staff or towards other residents. And this is these behaviors of risk are a real challenge faced in long-term care at the moment. And so how do you help facilities care for people who have these behaviors of risk and preserve the safety of the environment? So this is another opportunity in terms of technology. And where this all fits in is really developing health monitoring systems, right? So if you have a facility that has 100 people in it, but you only have a small number of staff at any given time, how do you monitor and support the care of everyone throughout that facility? Quality and safety is a really important issue in long-term care, and so these slides are really about data and the amount. So long-term care is like a hugely regulated and monitored place. They have to complete quarterly resident assessments, standard every person who lives in the nursing home. So there are 77,000 people who have these comprehensive, in-depth quarterly assessments. Then there's also healthcare administrative data that's available about long-term care residents, whether they go to hospital, how much, whether they pass away, whether they've been to the emergency department, how much contact with doctors, which drugs they're prescribed. All of this is data that's actually out there and available as healthcare administrative data. And on top of that, they have quite a comprehensive inspection process for these facilities. So this has changed a little with the new provincial government. They've cut back on inspections, but it used to be that homes were inspected annually, and then they'd have follow-up inspections, and there'd be inspections every time there was a complaint or a critical incident. And so all of this wealth of information about how a facility was functioning and the quality of their care was out there. And so this is an amazing opportunity in terms of more sophisticated data science sort of techniques. How can we make use of all of this data that's out there to understand better the quality? And a lot of this data is actually publicly available. So all of the inspection reports are publicly available. There are a set of publicly available quality indicators. So the top one is worsened pressure ulcers. The next one is potentially inappropriate use of antipsychotics in long-term care. And so since these indicators have been released publicly, which happened back in 2013 or 2012, there's actually been quite an improvement in the performance of long-term care homes in each of these indicators. But it's really left us still with questions about, does this actually represent improved quality of care in nursing homes, or is it just that the numbers are getting better? It's sometimes hard to know this. So we have a sector that's really closely monitored, and so there's lots of data, and that's a really important opportunity in terms of implementing different kinds of technology and artificial intelligence. Finally, the issue of demand is a really important one. So the wait time right now for long-term care in Toronto is over a year. There's an incredible demand for beds in these settings. In Ontario, outside of Toronto, it's a little bit better. It's more like 200 days, but not great. So we know that at present there's a backlog of people waiting for beds in this environment, and we know that the population in Ontario over the age of 75 is going to double in the next 20 years. It's projected that we'll need an additional 10,000 beds every year across Canada to address this sort of demographic bulge that is coming in the next 20 years or so. And so again, this is actually another fantastic opportunity because we are now facing an expansion of the long-term care sector. So 300 of the nursing homes that actually are already there, like the bricks and mortar, don't actually meet building codes. Some of them haven't met building codes since 1972. And they have licenses expiring in 2025. And so there's an enormous redevelopment push right now. So building new nursing homes to replace those homes or renovating those homes to actually meet the codes. And in addition to this, the provincial government has now promised 15,000 additional long-term care beds over the next 5 years. So that's an expansion of, so that's half of the beds turning over, and then another 25% on top of that, new beds. So what an amazing opportunity to incorporate more technology into the long-term care sector. And so this is really a time of growth and expansion and a real opportunity to think about what's next. So that's the context. So I wanted to make sure I laid that out for you guys before I got started into the world of technology in long-term care. So I don't think robot nurses are really the way forward, and so I want to put that out there. I don't think we're going to be replacing people with technology. It's really just about enhancing the ability of the people that we have to provide care. And there's two different kinds of technologies that we talk about when we think of technology and long-term care. So the first set are what we say are resident-facing technologies. So these are things meant to interact with the resident, designed to address a need of the resident, whether it be recreation or socialization. And it's really designed to improve the quality of life of the resident. So this is not the kind of research that I do, and so I just wanted to put that up there just to put that aside. There are people here at Kite who do this kind of research. Dr. Estelle, Dr. Mihailidis do research in the sort of resident-facing technologies, but that's not my area. My area is more provider-facing technology. So the kinds of technologies we can put into place to help support healthcare providers in the long-term care setting, find ways to enhance the care that they provide to improve the quality and the safety of the care. And even perhaps to evaluate the quality and the safety of the care that's being delivered in that environment. And so this includes a lot of different things. This could be different kinds of sensors, different ways of analyzing data, developing predictive algorithms, ways of collecting and processing documentation. Fundamentally, it comes down to health status monitoring and quality monitoring in the environment. So one important thing to know is that there is actually quite a bit of technology already existing in long-term care. And many of the nursing homes that I work in are actually more advanced than this hospital. We're still doing paper charts here. But electronic health records are actually widespread across the long-term care sector. The Point Click Care in particular is a company that has a bit of a monopoly, and I think it's like 80% of nursing homes in Ontario actually have a completely electronic health record. So that's an amazing amount of language-based data, right? A charting on residents every day by the staff. Not only do they have charting, at the desktop, but a lot of nursing homes actually have point-of-care documentation now, where staff carry mobile devices or tablets, or will have computers on the wall where they can input information about the care that they're providing, get reminders about different tasks that they need to do, review the care plans. So that's not the future, that's there. This is actually what long-term care is doing at the moment. So that's one kind of technology, but there's actually even things that we don't even think about representing technology. So video cameras. So many long-term care facilities have video cameras in their common areas and hallways, which are there to help the staff survey the environment. And we don't think about that, but that's a camera is a sensor, right? It actually is a vision-based sensor that tells us about what's happening in the environment. So at the moment, nursing homes mostly use them to be, they might go, oh, where's Mr. Smith? And they'll stare at the bank of screens and go, oh yeah, he's over there. But these video streams are for the most part not monitored. Very occasionally someone might go back to go and find out what happened if there was an incident or something. But and then in the Long-Term Care Act and in the regulations, it's required that nursing homes have some kind of wander guard system. And so that's a system to prevent somebody from leaving the home if they're not meant to leave the home. So that's usually an RFID type bracelet with a door lock that is triggered if they get too close to the door. So that's actually required. Same with nurse call systems. They have to be able to call a nurse from their bed if they need help. So these are technologies that are universally applied across all long-term care facilities. And so some nursing homes are actually upgrading these, and they're getting systems that also allow for internal locating so that they can find residents wherever they are on a map. And then there are technologies, things like bed alarms and chair alarms, all different kinds of alarms and warning systems that are becoming more ubiquitous in these settings as well. Although it has to be said that there is no evidence that these kinds of technologies actually improve care. So what kinds of barriers to new technologies? Cost, as I mentioned earlier, is the major barrier. Implementation, so if you already have a skeleton staff of present, how are you going to take the time to teach everybody how to use the new technology? How are you going to get everyone's buy-in to, if they're already, stretched to the limit, if this is going to cost them an extra 10 minutes a day, are they going to be willing to accept it? That affects the feasibility and the acceptability of the technology. I'll talk a little bit later about things like wearables and how feasible or acceptable those kinds of technologies are in this setting. The ethics are a very important thing to address. How much does it ethically permissible to survey people in these environments, especially when they are not necessarily able to consent to this surveillance because of their cognitive impairment. Lack of integration is something that needs to be addressed. So you can buy this technology from this provider and then this technology and then that technology, but nobody's going to be carrying 4 mobile devices or have 20 apps installed. Really, there has to be a way that it integrates into the systems that are there already. And then a huge problem in all healthcare settings, but I also see this in long-term care, is this alarm fatigue. Even just like the beeping that goes off when someone comes close to a door, plus the bed alarms, plus the chair alarms, plus any other number of like the nurse call system going off. We know that more than 90% of alarms in healthcare settings are false alarms. And so if you think you're developing a system that's going to notify the staff when something like that is happening, you have to think really carefully about how sensitive and specific your alarms are going to be to make them actually useful in this setting. Okay, hopefully I've set the stage completely now. So now I want to get into actually some of the research that we've been doing. And I kind of divide these into 2 sections. So the first is applications of some of this around quality monitoring. So how do we keep track of whether a long-term care facility is actually succeeding in meeting the quality standards that we would expect them to. And then a couple of things around applications for health status monitoring. So I'm going to go through each of these projects in turn. I'm just going to quickly check my time. Perfect. So this project was done by Purya Maheshwari, who's a master's student who just recently finished, and it's actually in the studies in press at the moment. And the question that we had was, wow, there's all this important information out there about the quality of care that's delivered in nursing homes. And we know that inspections are really resource intensive, right? If they're going to send an inspector out to a nursing home to be there for 2 or 3 days, you really want to know that there is a reason for them to be there. So can we tell which homes are having quality of care issues from the quality indicators that are used publicly reported? And that was fundamentally the question that we had in this research study. So we wanted to be able to predict inspection performance in nursing homes based on the quality of care indicators in the year before. So this was based on the 594 long-term care facilities. Those were the ones that had overlapping publicly reported quality indicators and inspection results. Inspection results, like I said, are publicly available. They're available as PDFs on the ministry webpage, and so Poria very cleverly found a way to web crawl and download them all and then convert all the PDFs into text and extract from them all the information about how many findings of non-compliance had been made in those facilities. And so what we did was we used the 3 categories that the Ministry of Health uses to categorize the long-term care homes: in good standing, needs improvement, or needs significant improvement. So we use the Ministry of Health categories, which are not really clear how they come up with those. And then we came up with some criteria. We met with some different stakeholders, the Ministry, Health Quality Ontario, Ontario Long-Term Care Association, and they helped us come up with some criteria to divide the homes into these 3 categories. And so to predict which category these homes would fall in 2017, 2018, we went back and looked at the data from 2016 in terms of different quality measures. So using 2016 quality measures, there were 9 of them, plus information about the region that the home is in, whether it's for profit or not, its size, some descriptions about the home, some contextual descriptors, like things like what proportion of the people in the home had dementia. We put all of these different features in the model and we tried to predict their standing in these 3 classes. So these are the inspection results that we pulled out of the Ministry of Health webpage. So this is 2017, 2018. And so the way we divided the homes was, so the citation severities go from least severe down to the very most severe, which is director's orders, which means like a home is actually instructed to close. And so we took compliance order as a kind of cutoff. So a compliance order is issued if a facility is told to fix something and then they don't fix it, or there's something that happens that's so serious that they say you have to fix this right away. And so if a home had any compliance order, up to 4 compliance orders, they got moved into class 1, so needs improvement. If they had 5 or more compliance orders, or any citation that was more severe than a compliance order, like a director referral or a cease of admissions, they were automatically put into class 2. Okay. So the results aren't great. So it's not very easy to predict which homes are the worst performing. I'll just we'll look mostly at our study defined classes. Overall, the accuracy was poor. It was about 40% of the time we could tell which of these categories a home would fall in. And we had the most difficulty identifying those 66 homes that performed the worst on their inspections in 2017. We only were able to identify 17% of those homes. It was much easier for it to classify the ministry homes, but in part that was because so few homes were in class 2 that if they just basically said that no home was in class 2, they were right most of the time. So that's why the accuracy is a little bit better. But overall, what we learned in this project was that it's not so easy to spot a home that was going to perform poorly in an inspection by looking at their quality in the year before. But we wanted to dig a little deeper because we wanted to know which of the quality measures, of the ones that we could predict, which of the quality measures were the most important. Because these quality measures actually have a huge impact on these homes. They're publicly reported. If you were going to put your mom in one of these long-term care facilities, you might go and look up one of these quality measures. And so homes get a lot of pressure to improve in these particular areas. And so does it make sense that they should be working hard to improve in these particular areas? And so what we found was that a lot of the quality indicators actually had no relationship with how the home performed in inspections. So things like worsened depressed mood, inappropriate use of antipsychotics, whether they had fallen in the last 30 days, these really had no relationship. The ones that actually seemed to matter the most were the ones that actually kind of intuitively make sense, that tell you something about whether the staff are delivering a good quality of care. So that one is restraint use, for example. So facilities with higher restraint use were much more likely to be categorized as class 2. And so you can see restraint use as a sort of failure of a quality of care process in the long-term care home. Somebody is being tied down, and that's probably not best practice. Worsened pressure ulcers was another really so if people have pressure ulcers, that's one thing, but if their pressure ulcers are getting worse, they're not healing, that's a sign that a home isn't responding in terms of quality of care. And then there's a couple that kind of were weird that didn't make a lot of sense. One is experienced worsening pain. So the homes that were class 1, so they were the ones in the middle, were less likely to report experiencing worsened pain. And that, I think, reflects in part the challenge with some of these indicators, in that they're completed by the nursing home, right? They report whether a resident has worsening pain or not. And so if you have a nursing home that's not very good at detecting pain, then they don't report pain. And so you actually, it's maybe a better marker of, maybe more pain is actually better. It's a sign of a facility that's realistic in their assessments of pain in their residents, right? Same with improved physical functioning. That's kind of interesting. So class 0 homes, so the homes that are in good standing, were much less likely to say that their residents had improved physical functioning. And again, there may be a lot of complex reasons for this. And one is that if a resident improves in their physical functioning, then the home actually gets a little bit less funding, because you get funded based on the care needs of the residents who live there. And so there's an incentive not to report that your residents are getting better. And so maybe these homes in good standing are good at knowing that and not reporting improved physical functioning. So the next steps in this project is that we're gathering more and more sources of long-term care data. We have a complete set of quality indicators, both publicly reported and not publicly reported. I'm really interested to look to see if there's a contrast between those two. Are the publicly reported ones somehow distorted now that they've become publicly reported in terms of the data quality? We have additional features like wait times and the infrastructure of the facilities that we're going to add into our models. And in consultation with our stakeholders, what people have said to us is that it's really important to focus on predicting the most serious inspection deficiencies. Like, they don't really care whether the inspector found that like a light was burnt out, like that's not so important to them. But was there abuse? Was there neglect found on inspection? And that's way more important. And so that's, I think, where we're going next with these studies. So next I want to talk about falls in long-term care. And so I put this graph up here to show you that in contrast to many of the publicly reported quality indicators, falls has not gone down in long-term care. Falls are going up. And that's a reflection in part of this increased complexity of the population there. 16% of people in long-term care will fall in a month. So this is called the Ambient Study, and this is the study team. And our aim is really to find a way to make use of a simple long-term care technology, which is a video camera, to use this to help monitor health status of the residents. And the way we do this is that we think about using this video to measure gait. So walking is a really important marker of health status. We know that people's motor control gets worse when they are unwell, if they're confused, if they're depressed, if they have cognitive decline. And if we are able to detect this change in walking, we think that it'll tell us something important in terms of risk, not just in terms of falls. That's one way. If someone's walking more poorly, you would expect there'd be a higher risk of falls. But also it might tell us something more generally about their health status, and perhaps we can predict that they're declining in health and they're facing a hospitalization or emergency visit to allow us to intervene more quickly and prevent those events. So we developed a system that uses computer vision to analyze gait. It has a lot of really important advantages. It captures people's natural movements as they walk down a corridor in their home environment. It's low effort, no markers, no wearables. We can track all of their joints, so it's not like some people put accelerometers on the trunk or on the ankle. You can only measure some of them. Here we can measure their entire anatomy. And we can do assessments every time they walk down that corridor. We're not restrained to only do assessments when someone's present to assess them. The disadvantages of our system, as you've discovered so far, is that if somebody doesn't walk, we can't measure their walking. You need people to be walking down the corridor to measure it. And that rollator baskets are not great because they block people's legs. But if they have just a seat, that's okay. But baskets, not good. This is the Ambient Study. We did a prospective observational study here at Toronto Rehab on the Specialized Dementia Unit. The length of stay here is about 60 days, and we looked at ambulatory patients on this unit, and we did a whole series of clinical assessments, as well as tracking clinical events like falls and medication use, to understand a bit better about the relationship between gait and these events. So our first version of the system used a Kinect camera. Doesn't seem to want to go. We used RFID to identify research participants. They would, is it going? No, it's not going. I stopped it. That was my fault. Play. And is it running? Oh, it's running there, but not on my screen. That's very good. Okay. So the way this worked is that research participants had these tags ironed onto the inside of their pants. As they came down the corridor, the tag would trigger the camera to turn on, which would record them in a short bout of walking. Using that bout of walking, we could then use the Kinect to track their skeleton, and from the skeleton extract gait measures, and then over time track each of these gait measures to look to see if there were any changes in their walking over time. So that's Ambient 1.0. We published a feasibility study based on the sort of first, I think, 19 people in this to show that we are able to collect longitudinal gait measures over time. So the top bar is, for example, step length variability, and so you can see on the left is someone who fell quite a bit. The red lines are falls and what their step length variability looked like, and on the right is someone who didn't fall. And so we think that there's something interesting there in terms of the variability that people exhibit in their gait, and our hope is that over time that they actually will be able to detect change. In our study, because we only collected data for at most sort of 60 days in our participants, that we didn't really have enough time to really see that much change, but that's where we're going. So in this study, in total, we had 64 consented, some people who we didn't collect very many walks for. In the end, there were 52 people included in our analysis, and of those 52, 28 fell during their admission. This is the sort of table one of our participants. When you look at clinical variables that were associated with falls, the men fell a bit more than women. The people who walked less fell more than who walked a lot. Some clinical measures, POMA, balance, and gait measures were associated with falls, as were their function, measured by the CAT scale. It's a measure of activities of daily living. The more severe neuropsychiatric symptoms were associated with falls, as was impulsivity. A falls risk assessment called the Stratify was associated with falls, as was falls history. So half of the people who fell in this study had a history of falls in the previous 3 months. So what we did was we extracted these gait features from the Kinect sequences. I think there were 30 or so in total that we were able to measure. And then we looked at their association with the number of falls that people had during the study. And we found that individually there were a few that were pretty strongly associated with falls. Step width, which kind of makes sense. That's people, maybe a marker that people who were unstable, step time. And then these measures of stability. So this is the margin of stability. Different measures of margin of stability. And so that was one of the things that we found that was interesting and unique about this system, is that we can actually measure gait stability or estimate gait stability using these markers. So we would estimate the center of mass using the spot between the hips, and look at the right and left ankle, and then look at the way that the center of mass moves between the left and right ankle to estimate the margin of stability. And this proved to be one of the most important predictive factors, so a more direct measure of stability to predict the number of falls. So this came out just recently in the Journals of Gerontology A. So let me know and I can send you the PDF. We're also now working towards the idea that can we do short-term prediction of falls using gait stability. For example, we can, using very like a simple prognostic model, looking at like a baseline assessment using the ambient system, can we take these people who are all, frankly, at high risk of falling, and divide them into people who are at ultra high risk of falling, like imminent risk of falling, and people who are just at high risk of falling. And so when we do that, we found that, we could come up with this ultra high risk group who we think have a 1 in 5 chance of falling in the next 5 days. And then a 60% chance of falling, and then a better than 50% chance of falling in the next month. So we can actually detect ultra high risk and separate them from the high risk using these gait stability measures. And so then where this project is going is starting to use more sophisticated machine learning to actually look at how the gait measures are changing over time to come up with a more dynamic measure of falls risk. Our initial models use the last 4 days of walks and compare that to the baseline period of walking, and we can identify about 3/4 of those who are going to fall in the next 6 days with models like that. So this is kind of, I don't know, these numbers don't sound impressive, but nobody's ever tried to say who's going to fall in the next 6 days. Most falls risk assessments are about who's going to fall in the next year. So we're really shortening the time frame here and giving a more precise idea of who's going to fall. So where this is going now is we're moving away from Kinect. Again, we don't want to be installing Kinect cameras in long-term care. That's not going to happen. But like I said, video cameras are everywhere in long-term care. Video cameras are in corridors. And so we've actually developed a way of pose tracking from video. This seems to be actually perhaps even more accurate than the Kinect at the tracking joints. In our initial benchmarking, we are able to extract this very similar gait measures from the pose tracking from a simple RGB video, and that these measures are actually also strongly associated with falls in this population. So this is a work by Becky Ng, who just finished her master's thesis in this area, and hopefully this manuscript will come out soon. And so this is where we're going with this project. Oops, next slide. It's thinking. Did it go? Sorry, the next slide has a video on it, so I think it's, oh no. It's just said it's not responding. I've got a warning. I'm not going to restart. Wait for the program to respond. Okay, so where this is going, and hopefully Microsoft doesn't quit on me here, is that we've moved the ambient system to Lakeside, which is a long-term care facility. So like I say, people live in long-term care for up to 2 years. We were going to, oh, it worked, okay. Follow people longitudinally in that setting. We are focusing on post-tracking in video. The video is unfortunately not working. Oh, it's going. No? Was it ready? Okay. The video just shows what the pose tracking in video looks like, which is pretty cool. And we can certainly send out a link if anyone is interested in it. It's on YouTube. And so so that's where the study is now. We have an active longitudinal study going on at Lakeside using video and post tracking in video. And so that's the next step of that study. I'm going to quickly touch now on detecting agitation in dementia. And so this is a study with a lot of different investigators that was also based here on this specialized dementia unit. It's actually an ongoing study. We're still recruiting. We're down to our last 2 subjects. And the idea behind this was can we develop a sensor system that can detect when someone is becoming distressed, when someone is displaying signs of agitation or even aggression, so that staff can respond and support them in that time. And so in this study, we used a wearable sensor, which was the Empatica E4, and it measures motion through an accelerometer, blood volume pulse, electrodermal activity, skin temperature. We also used video cameras in this study, with the idea being to annotate the agitation events to provide ground truth, so using a combination of clinical notes and the video imaging. And what we've found is that there are some clear signals that you can pick up, but the problem is that these signals are not very specific, right? So you can see an accelerometer movement when someone is becoming agitated, but are they becoming agitated, or are they swatting away a fly? Are they are they distressed, or are they exercising? It's really hard to distinguish those things. So far, with our data collected from 18 patients, we have had 376 agitation events captured, lasting from 1 minute up to 3 hours. And we've been able to analyze preliminarily data for 16 participants, as 2 of the 18 did not have any agitation events, and so they're not included here. And so what we're able to show is that using data from all of the different sensors in the wearable, so motion and the blood volume pressure, EDA, and temperature, we can detect an agitation event with an accuracy of about 86%. And that when you add all the sensors together, it's better than any single one of those sensors on their own, or even combinations of 2 of the sensors. It's something about adding all 4 of those sensors together provides us with a better signal. So that's where the study is. I mean, we're going to still collect a couple more people, but I think ultimately the results will be the same. That there is something there in terms of the wearable. We can detect, but that there's probably some issues around the specificity of it. And there's also issues around the acceptability. So we had quite a number of people who we couldn't put the wearable on. They didn't want it. They were very clear. They were expressed strong dissent. Staff found it was a bit stressful. The patients found it quite easy to remove the wearable. We lost one wearable. Those things that cost thousands of dollars. So there are some issues around wearables in this setting. It has a very short battery life. It had to be taken off and charged every night, as well. The data had to be downloaded every night. There was a lot of issues around signal artifact if you didn't put it on tight enough. Anyway, so I'm not sure that the answer is in wearables. And so this is where I think we should go in terms of the next steps in this study is around more low effort sensing technologies. And so this is a project we just got funded through. The Spark was actually using some of the video images from this project to do computer vision for anomaly detection. Like, can we detect in the videos that agitation is happening? Can we detect that something is happening that is of risk, that's not supposed to happen? And this has already been done, say, with falls detection. People can detect in video that someone has fallen, but can we do this with agitation or aggression is an interesting question. And then the other thing that I raise as an interesting question is, is it really important to do real-time detection and prediction? Do we really think we're going to get to the point where we're going to have a clinically useful algorithm that will not give us false positives 90% of the time? Is it more valuable in terms of clinical decision making to end up with some indices or scores or some way of measuring the severity of a behavior over a period of time that can be then used by clinicians in making decisions about treatments or interventions? And so this is where the STIX project comes in. This is the last one I'm going to quickly talk about. This project is in the very early stages. It was just funded by an Age Well Catalyst grant. And so this is about developing indices for clinical support using a technology that's already widely present in long-term care, which is real-time locating systems. So many facilities are upgrading to these kinds of systems, and mostly they just use them to find someone in space or find an asset or stop someone from leaving the building. But these systems also let you do things like geofencing, warning systems. You can use it to monitor staff performance, like how quickly people are responding to call bells. You can watch the way people interact with the environment, like if you put a new picture here, do people stop and look at it or not? But even a step further than that, like a higher level of analysis, is do patterns of behavior in terms of where people are in time and space. Does that tell us something about their clinical status? And so that's what the STIX project is about. So we're really trying to accelerate the use of these kinds of location technology and use this data to help improve health and well-being of people in long-term care. An example, so this is, we come up with the different kinds of ideas, like what can where people are in space and time tell us about their health? So we can measure how much time they're spending with other people. We can come up with an index for social engagement. We can measure how much time they spend by the exit as a measure of like whether they're trying to leave or not. We can measure how much physical activity they have, their gait speed, how many times they go to the toilet. All of these things are things we can measure by their location. And so we're waiting to get started on a pilot study at Toronto Rehab on our specialized dementia unit, as well as a second long-term care site. We're also working on an ethical analysis of this kind of technology. How can we ethically monitor people in their location and time, and how do we implement these kinds of technologies in an ethical way? And then we're also planning a pilot study of an environmental change on the SDU. We're going to put up door decals just to see if we can influence the way people move through their space by changing the environment. So there's a really cool company called True Doors that make these door decals. So that's STIX. Okay, so I'm sorry, I've run a little bit. I want to leave time for questions. So my key points are that long-term care is a home. It's not an institution. It's not a hospital. And so, how we think about technology in this environment really has to take that into account. There's this rising complexity of resident population that's not matched by a rise in resources, and so, there's this opportunity to try to address that gap. Long-term care is a rich source of data about residents and quality of care, and so there's opportunities to use that data. There's already lots of technology in use in long-term care, and so how do we leverage these technologies that are already there? And that we have to make sure that any technology we think about for this environment, that it's simple, that it's low effort, that it's integrated, and that the information it provides is clinically meaningful, and that it's actually actionable by the long-term care staff. We can't make their lives harder, we have to make their lives easier. And so that's the end of my talk. So I'm happy to take questions. Either, I know there's maybe some people logged in there, if they want to send a question by comments. Or any questions in the room? I've stunned you into silence.
I don't know whether, that's terrific talk, but my memory is poor, but a long time ago when I was working in this sort of area, there is a scoring system for the workload of patients in long-term care. Mm-hmm. RAIA or something?
The RAI-MDS, is that what you mean?
RAI-MDS
yeah.
thing. Is that of any value in helping to predict how the workload in a nursing home is related to performance of the place?
Yeah, so so the quality indicators that we used in our study are derived from the RAI MDS. And you're right, so we're using a kind of processed level RAI MDS in terms of like actually just using the raw RAI MDS data. I think that there's a lot of opportunity there. There are plenty of data scientists out there who use this data. I think Jen, is she here? She's gone. Jen Bethel was here a second ago. So she, has done research using the health administrative data. But there isn't a lot of machine learning happening with the health administrative data, and I know that ICES and Vector are working to make that data more available for that kind of analysis. And I think that's where things need to go, is to have a look at the raw data rather than these indicators that have been processed.
But you did mention that sometimes the nursing home environment uses these to boost their income, their revenue. In fact, I know there are consultants you can hire to increase your number, your score,
yeah.
Right?
So there are probably elements of the RAI that are distorted, right, because of that, because they're used to calculate the case mix index, which determines funding. But not all of the RAI is used for that, right? So there are probably elements that are less affected by that. And so you're right, in terms of the quality of the data, there have been studies that have looked at the quality of the data, but most of that has happened in the States. And in Ontario, there have not been any explicit sort of auditing, or none of that happens right now. So the data is what it is, right? It may have some flaws.
Okay, quick question. So once you know that somebody's going to false, probability of them falling like 6 days, 75%.
Yeah.
What do you do then?
Yeah. So this is a question that we get a lot. So in part, the thought is that once we can do this, right? So at the moment, it's not clear that we can do this, but once we're in a position of being able to say who are the 10 people in this facility that are at the highest imminent risk of falls, then you can actually target interventions that are resource intensive towards those 10 individuals, right? So then the things that have been shown to be effective, I mean, basically, if you have somebody with you, you're much less likely to fall, right? Like if you have more supervision and more support, you're much less likely to fall. So, but you can't provide an enhanced level of supervision to 150 people, but you could provide an enhanced level of supervision to 10 people. And so that enhanced supervision combined with a comprehensive medication review, these people are flagged, they're reviewed comprehensively by the team, they're given extra rehab, they're given hip protectors, right? So maybe they are gonna fall, but we just do harm reduction with them, right? So, so the nurses know these 10 people get their hip protectors. If you say everyone in this nursing home is getting their hip protectors, that doesn't happen. Implementation of that doesn't work. It's been shown that people, the acceptability to the staff and the residents means that they can't follow through with that very effectively. So it's about intensifying the resources towards those people who are at most imminent risk and doing a lot of harm reduction and possibly rehab if that's identified as what's appropriate for them. Yeah. Oh, yeah.
One here online. Louise Bribois. I am curious about doing research in long-term care facilities. Do they have their own REBs? How does informed consent work with those residents?
Sure. We are working now with Lakeside, which is actually part of the University Health Network. So they have our REB. So we get our approval here and then that translates there. In other nursing homes where we've done research before, we get approval here, and some nursing homes will have local committees, but not actual full boards, but they will review our protocol and our approval here, and then they will allow us to move forward with the research at their setting. Sometimes there needs to be an agreement signed saying that they recognize our REB as the board of record. In terms of consent, that is it's an important thing to address. So at Lakeside, all of the residents are assessed for ability to consent before they, at the start of the study, and thus far 100% actually have been found not able to consent. In this particular population of people who are ambulatory in long-term care, almost all have cognitive impairment, because if they're walking and they're in nursing homes, it means that they don't have the physical care needs, which means that they have the mental care needs, right? So anyway, so 100% thus far have been found not capable, and then we get decision-making consent from the family, but we built into the protocol that if they are exhibiting dissent to the research activities, then we then we might remove them from the study. Oh, sorry, there was a question, yeah.
All your research so far that you presented is while people are awake, moving hopefully, or something like that. Is anybody looking at gleaning data from patients while they're actually asleep or should be asleep? There are lots of systems out there for monitoring agitation in bed and stuff like that. It's quality of sleep.
Yeah, so, you know, we actually had in our detecting agitation study initially, we had some bed mats. You know, so far we haven't, the quality of the data that we got from the bed mats wasn't great, and there probably are better technologies out there now than when we first started that study. It's tricky because residents don't always sleep in their own beds. They get in and out of their beds. There's, you know, we just found there were some feasibility issues with just having a mat in the bed, and but there hasn't been a lot of research looking at sleep quality in long-term care in particular and its relationship to some of these things.
Besides improving patient outcome and experience, what are the incentives that long-term care they would purchase this expensive technology to be able to say monitor if someone's agitated?
Yeah. So
is there like a reimbursement model or some sort?
No. So there's no incentive. Like there's no way to get them to buy anything expensive, which is why we're trying not to do expensive. So that's why I don't think Empatica watches are going to work. You know, no nursing home is going to invest in $1,000 watches for all their residents. It's just not feasible. But that's why I think, so they already have invested in their video surveillance cameras. And so if you develop a software solution, which just takes a video stream, runs it through some algorithms, and then identifies, anomalies or identifies measures gait, or, I think that actually is a software solution, which hopefully would be relatively inexpensive compared to a whole hardware technology system. So that's why I'm heading in that direction rather than developing things. Lisa, hi.
Hi. Thanks for your talk. I'm wondering, so part of your talk was making the argument that health status monitoring in nursing homes is kind of like a different beast. So do you think there's something qualitatively different about the kind of monitoring systems that you can implement in that space versus the kind that are implemented in like people's private homes or hospitals? Like, or is it just the regulations and the decision making is different?
Okay, I keep forgetting to repeat questions. So Lisa's asking, is there a difference between health monitoring systems as they apply in long-term care compared to how they might apply in other settings, like in private homes and things like that? I think the key difference is that in a long-term care home that you're dealing with the communal aspect of the residential setting, and you're dealing with people who are, for the most part, aren't aware that they're being monitored, and are not able to consent to that. If you're setting something up in someone's private home, presumably for the most part, unless you're dealing with someone with dementia in their home, but then you're probably still dealing with the similar issues. So I think that's fundamentally one of the key things. And then the other difference in long-term care is that there is 24-hour support there, right? So you can have a health monitoring system, and if there's something that the problem that's detected, have staff on site, have access to a doctor 24/7, which you don't necessarily have at home, right? So if you have a health monitoring system at home and it detects a problem, many people, their only option would be to go to emergency, right? And so then, does that actually solve the problem of overuse of our acute care system, or does it just create a new problem? But within long-term care, ideally, you have a place where you can maybe, with early intervention, can address an issue before someone might need to go out. Yeah.
Yeah, great. Thanks for the talk. I have a question about the monitoring. So you're moving towards a surveillance system in the long-term care with video camera and so on. Have you tried investigating what are the main concerns about privacy from these people and how to tackle this?
Yeah. So this is a question about privacy with the surveillance, with things like video cameras and things. So people have done studies about what people think about video cameras in long-term care. And so there is a literature out there about that, for the most part, I mean, they're there, right? People tend to think that the benefits outweigh the risks. A lot of the literature is around privacy for the staff. How does staff feel about being surveyed in their workplace, which I think is actually also a big issue. I don't know if you guys know about, like, there was a whole trend towards like nanny cams in long-term care for a while there. People were putting nanny cams in their loved ones' rooms to monitor staff and their interactions with their loved ones. And some facilities, have kind of seen this as a losing battle, and they've actually told family members that they're welcome to put cameras in the rooms, just as long as they don't conceal them, because obviously that impacts on trust and things like that. So there are facilities now that have a policy that it's okay for a family member to put a camera in their room to monitor their family member. Anyway, so yes, this is something that we have to consider, and it is being thought about, but also the technology is just running ahead of us as well. Yeah. Great. Thank you very much for coming, everyone.